All right. Have a great conversation, everyone. Hi, welcome everyone. We are so pleased to have you all here today for our webinar on lessons learned from CalAIM. We'll get started in just a couple minutes. I know for those in California time, it is 9 a.m. sharp, so I want to give folks a minute to trickle in. Delighted to have everyone here. Just going to give it another 30 seconds or so, and then we'll get started. You all are very prompt. Okay. Welcome again. We'll dive in. I think there's still some folks joining, but we can do sort of the overview. Welcome. We are so happy to have you here for today's webinar on lessons learned from CalAIM and the impact of California's new housing-related services for people experiencing homelessness. My name is Alyssa Weiss. I'm from Home Base. I'll share a little bit about our organization in a minute. We're really excited for today's conversation. We think it'll be a great discussion about lessons learned from the first 3 years of CalAIM and the Housing and Homelessness Incentive Program. We hope this webinar is beneficial to those in California, but also people in states that are also implementing or considering Medicaid waivers that cover housing services, or really considering any sort of healthcare housing integration initiatives. We know that's kind of really picking up steam nationally, and we're just thrilled to be able to highlight the work of California in our discussion today. For those who don't know us, Home Base is a nonprofit organization that is entirely dedicated to preventing and ending homelessness. We are based in San Francisco, but work nationally, working at the local, state, and federal level to support communities in the work of ending homelessness, reducing poverty, and fostering thriving, inclusive communities. For the past decade, we have developed a practice dedicated to the intersection of healthcare and homelessness, and have been deeply engaged in the rollout and implementation of California's recent health and housing initiatives, like the ones we'll be discussing today. We had an amazing team that worked on this project. You'll meet several of my colleagues today. And I am also thrilled that we're joined by a really amazing group of practitioners for today's panel discussion. You'll get to know them a little bit more in a few minutes. A few webinar tips for today. You all will be muted during the webinar, although folks can ask to come off mute if you have questions during the Q&A section. Captions are available for those who want or need them. Feel free to drop any questions into the Q&A function throughout the webinar, and we will do our best to answer your questions through that function and also during the Q&A portion of the panel. You can use that Q&A function to let us know if you're having any tech issues. And lastly, we are recording today's webinar and plan to share the recording and slides after the presentation today. During today's webinar, we'll cover the background of California's recent health and housing initiatives, share lessons learned from CalAIM and the Housing and Homelessness Incentive Program. Then we'll get into the main event, a terrific panel discussion with 4 practitioners who are deep into CalAIM implementation, and wrap up with recommendations and next steps. Today's webinar is based on a series of reports that Homebase just released. You can find them on our website. They were the result of over 40 interviews and listening sessions with individuals receiving CalAIM services, providers, homeless systems of care, managed care plans, state officials, and more. And absolutely none of it would have been possible without the support of the California Healthcare Foundation and our absolutely wonderful program officers, Melora Simon and Michelle Schneiderman. So with that, I am so pleased to welcome Michelle Schneiderman, MD, who is the director of CHCF's People-Centered Care Team, which works to ensure that Californians receive responsive, comprehensive, and coordinated care that supports their health and well-being. Prior to joining CHCF, Michelle served as a medical director of Alameda Alliance for Health, and before that, she spent more than 14 years as a clinical professor and physician leader at UCSF. Welcome, Michelle.
Thank you, Alyssa. It's so nice to be here this morning, maybe this afternoon for some of you. At CHCF, improving outcomes for people with complex needs, particularly those experiencing homelessness, is one of our core priorities. To do so, we champion cross-sector collaboration between healthcare, homelessness, and housing providers to scale effective care models. CalAIM has been transformative in this space, and who better to help us understand its impact than Homebase, a key TA provider and innovator in CalAIM implementation. We partnered with them to assess the early lessons from CalAIM's housing-related services and the Housing and Homelessness Incentive Program. Today, I'm so excited that Homebase, along with leaders from 4 California communities, will share findings that reveal how people experiencing homelessness are accessing these new Medi-Cal housing services and how these programs are reshaping the ecosystem of providers, homeless systems of care, managed care plans, and government agencies. Their analysis of successes and challenges offers a roadmap for improving enhanced care management and community supports while informing future cross-system collaborations that can better serve our most vulnerable Californians. I am so grateful for their tremendous partnership and excited for you all to hear what this group has learned. Tara, I think I'm passing it to you.
Thank you, Michelle. Before we dive into some lessons learned, I'll briefly provide some context on California's recent health and housing system integration initiatives. In 2022, the Department of Healthcare Services launched several major cross-sector initiatives to leverage Medi-Cal resources for people experiencing homelessness. These initiatives were born from recognition that housing is a key social driver of health and that addressing homelessness requires both housing resources and integrated healthcare services. CalAIM, which stands for California Advancing and Innovating Medi-Cal, leverages federal Medicaid flexibilities to pay for housing-related services, including enhanced care management, or referred to here throughout as ECM, and community supports. And the Housing and Homelessness Incentive Program, also referred to as HIP, which was funded through one-time American Rescue Plan Act funds to incentivize collaboration between healthcare and homeless response systems. Together, these initiatives intended to create sustainable funding streams for housing-related services through Medi-Cal, while also incentivizing lasting partnerships between the healthcare and homeless response sectors. Enhanced care management, or ECM, represents a significant evolution in how care coordination is delivered through Medi-Cal. ECM is a mandatory statewide benefit that managed care plans, or MCPs, are required to offer to members who meet eligibility criteria. It delivers comprehensive care management to Medi-Cal members with the most complex needs. And the program provides eligible members with a care team or staff who help that individual navigate physical, mental, behavioral, and social systems and coordinate their clinical and non-clinical needs. ECM delivers services through a field-based model where providers meet members where they are in encampments, shelters, or other locations. By taking a comprehensive approach, ECM recognizes that people experiencing homelessness often have multiple overlapping needs that can't be addressed through a single system, and provides intensive care coordination necessary to help members access the full range of services they need. Additionally, the state has prioritized several populations of focus to receive ECM, including individuals experiencing homelessness. This structure helps to address the fragmentation that can occur when vulnerable individuals attempt to navigate multiple systems simultaneously, helping to reduce unnecessary utilization of emergency services. Community supports are optional services that MCPs can offer to address social drivers of health. While there are 14 different services in total that are intended to address members' health-related social needs and prevent costlier, more intensive healthcare interventions like hospitalization, several are specifically housing-related supports that aim to help members find and maintain housing while connecting them to other needed services. These include housing navigation, housing deposits, and housing tenancy and sustaining services, also referred to as the housing trio, as you may have heard. By January 2026, California will add transitional rent as a mandated community support, further expanding the housing resources available through Medi-Cal. This program provides up to 6 months of rental assistance for Medi-Cal members experiencing a risk of homelessness, including those with significant behavioral health needs, aiming to bridge the gap between temporary housing and permanent solutions. Launched alongside CalAIM, the Housing and Homelessness Incentive Program, or HIP, sought to accelerate collaboration between managed care plans and homeless response systems using one-time funding through the American Rescue Plan Act. Through HIP, MCPs could earn one-time incentive funds by meeting a number of metrics, including partnering with continuums of care and counties, data sharing across systems, increasing successful housing placements, reducing entries into homelessness, and increasing utilization of ECM and CS. HIP gave MCPs flexibility in how they invested these funds. They could support local homeless response systems directly, build infrastructure for cross-sector collaboration, or expand service capacity. This approach created meaningful financial incentives for healthcare plans to engage deeply with homelessness issues, establishing relationships and infrastructure that continue beyond the program's funding period. And now I think I will turn it over to Jillian to discuss some of the lessons learned from the implementation of these initiatives.
Thanks, Tara. Hi, everyone. Yeah, really excited to be able to share with you all some of the high-level lessons learned that we get into much more detail in the report that Julie linked earlier, and I'm sure we'll link multiple more times. But if I'm gonna talk about some key lessons learned or the implementation successes and challenges from HIP, and then I'll go into some more detail about the similar successes and challenges that we've seen in enhanced care management and community supports implementation. Just to give you a taste, and again, there's a lot more detail in the materials that we have on our website. So looking at HIP specifically, which Tara just finished wrapping up talking about, this is actually a program that has ended, but we still wanted to, it really helped catalyze some of the successes we've seen in ECM and CS as well. And so really wanted to make sure we were highlighting some of the successes and challenges and lessons learned from HIP as well. So one of the really key successes that came out of the state offering HIP as a program was it was, as Tara said, very flexible financial incentives. And there was also really minimal bureaucracy, especially compared to a lot of different kinds of state funding programs. And that combination of flexibility and minimal requirements was really able to catalyze this cross-system collaboration between managed care plans on the one side and homeless response systems on the other. So really wanted to focus specifically on that really key element of the program that was a really big recipe for the success of it. And some of those incentives, like we're talking about it spurring relationships across the sectors, and what that looked like very specifically was we saw COCs or homeless response systems really partner with or strengthen their partnerships with managed care plans in their communities. In a lot of instances, managed care plans were actually really integrated into homeless response systems, not just kind of collaborating with, but really becoming part of those response systems. And also we saw hiring of housing-focused staff in some managed care plans, in addition to health-focused folks really joining into the COCs, or the homeless response systems. And we also saw really critically, as Tara mentioned, managed care plans could use their earned funds through HIP really flexibly. And so we saw a lot of investment directly into homeless response systems in different communities across the state. Which really was able to kind of fill gaps that were not able to be filled with the traditional resources that COCs often have. On the other hand, there were certainly some challenges and barriers that we saw with HIP. It was a really time-limited program due to the funding that was being used for it, and so that obviously created a lot of challenges when you're having to kind of plan for, implement, especially a program that's requiring or that's meant to facilitate cross-system, work that hasn't happened in a lot of communities. And so that really short program, and there was lots of information that was changing kind of week to week or month to month. Guidance was a little bit slower getting out. And so that did kind of compromise the ability of the MCPs and the COCs they were collaborating with to really fully kind of build that partnership in real time. And also, it was a health system program. The dollars were coming through the managed care plan on the health system side, and as was the information. And so that kind of uneven power dynamics that were just inherent in the program, again, sort of led to some missed opportunities. So a lot of challenges as with any new program, but certainly still was able to really catalyze some great cross-sector collaboration. So switching over to ECM and community supports, again, these next few slides are really distilling a tremendous amount of information. And so this is really meant to be high level, but just to give folks a sense of some of the most critical implementation successes. So first and foremost, right, these are services that were paid for by Medi-Cal. So really enabling very critical services that folks experiencing homelessness can really benefit to actually get to those folks. And really importantly, those services are being funded by the health system rather than, the really scarce resources that homeless systems of care hold. We mentioned that HIP helped catalyze this, but this continued implementation of ECM and community supports that sort of built from that is really enabling really, really strong relationships to be developed between managed care plans and both homeless systems of care, but also the specific providers that are providing ECM and community supports as well. And that in turn is developing this network of additional folks, and these stronger relationships is in turn creating a better system that serves people experiencing homelessness better. And one final thing we wanted to, kind of note is that in some places, counties are actually really supporting this implementation through acting as an administrative or, contracting hub, or kind of supporting that administrative or contracting need of ECM and CS, so that not every individual provider, has to do that, so that there can be more folks who are really experts in serving people experiencing homelessness, providing these services, supported by their counties doing some of this administrative support. On the other hand, some of the challenges that we've seen that we wanted to really highlight, and again, lots more detail in the reports. Some of the key ones are, this is a health system resource, and so there are lots of administrative requirements, and many of them are new to folks, especially providers who have not previously contracted with managed care plans, have not previously provided health system resources, or had to bill Medicaid. So that's obviously a challenge to kind of build up the network. Although there have been lots of efforts to spread information and make sure folks are aware of this, both enrollment in and even just awareness of enhanced care management and community supports is still quite low, especially to get folks experiencing homelessness connected. And so while we're seeing really great services being delivered to folks who are connected, there are still lots and lots of eligible folks across the state that are not yet either aware of, or at least not enrolled in these services. There is a lot of, kind of similar to the administrative requirements, a lot of just financial pressure, a lot of complication for providers who are experiencing homelessness. The system is not, we've been focusing on folks experiencing homelessness, but these services are not just eligible. That's not the only eligible population. And so it wasn't a system that was, or a service package that was specifically designed for folks experiencing homelessness. And so the actual realities of connecting folks who are, especially living unsheltered, for example, to these resources is a little bit different, more complicated, can take longer. And so there can be both some financial pressure created by the sort of extensive services that are needed to reach folks and connect them to these services. And also there are specific limitations to using CalAIM that aren't necessarily present for some when you're serving folks with other kinds of resources. And so, for example, people experiencing homelessness often work with lots of different providers in the homeless response system. And there's a little bit more to it when you're talking about, a person can only have one housing navigation community supports provider, for example. And so that's led to a little bit of confusion for new providers and some competition as well. There's also disconnected systems, right? Not everyone is using HMIS. The referral systems are not necessarily all streamlined. And so that's created some challenges with respect to actually referring folks to these resources and also just the actual care coordination once folks are connected. And finally, we note here that there are just different perspectives. These are two, separate systems, the healthcare system and the homeless response system coming together to serve a population of folks who need resources from both. And the fact that there are different perspectives of how housing-related supportive services, like how long they should be needed, like how those connections happen, are just differing from different systems. And so that's obviously provided some growing pains as well. These are not meant to be universal experiences, but we wanted to assure people that there are certain challenges or barriers that we've heard pretty commonly that are not singular, right? There's not just one person or one county that's experiencing these. And so while this is by no means meant to suggest that everyone that's providing ECM community supports is experiencing these exact challenges, we've heard the opposites of some of these from some providers and some communities, but just wanting to reassure some folks that if it's, for example, taking you longer to engage with and provide services to folks who are unhoused, especially unsheltered compared to other Medi-Cal members, if the rates you're receiving are not quite sufficient to cover the full range of costs that it's taking to provide these services, if you're feeling or seeing kind of competition across providers, especially who didn't kind of previously have that sort of sense of competition, if there's not tremendous utilization or is relatively low in your community, if you're having a hard time connecting folks who are maybe prioritized lower on your community's coordinated entry prioritization list to these resources. These are things we've heard across the state in different communities, different types of communities from different types of providers. And so again, not intended to suggest everyone is feeling this, but if you are, you're certainly not alone in that. And then finally, again, I know I've said this a few times, but I feel like it bears repeating that this is really high level. We wanted to kind of pick out what we thought were really highlights from both the challenges and successes and some lessons learned from these. But there is a tremendous amount more detail if you want to dive into the materials after this, hopefully. But again, we wanted to kind of lift up a few really key takeaways that are from looking at an analysis of both HIP and community supports and ECM kind of all taken together, like what have we seen emerge from the state's implementation of putting out of both of these programs. And so there's a few things we really wanted to highlight. And especially, I'll just call out a couple of these here. One is that healthcare and particularly managed care is a really increasingly important player in the actual homeless response systems throughout the state. And with that, reality comes just really incredible opportunities to help address homelessness using healthcare resources. We also have seen that there is still a need for additional coordination, better outreach and information sharing, more alignment and integration across systems. So as much progress has been made, we really want to kind of acknowledge that there's still more to be done in order to really realize the full potential of CalAIM and systems like it or programs like it. And one of the ways to kind of move in that direction is to really continue to streamline the complexities and the processes and really to better integrate these systems, continue to better integrate them to both increase connection to these resources and also just like improve the service delivery of them. And I do want to just touch on that the last piece, which mentioned a little bit in the HIP, but we've seen kind of looking at both HIP and also these CalAIM housing related programs that it really is a combination of both an infusion of really flexible funding that can really like get change going or kind of like kickstart some of this collaboration and change, combined with sustainable ongoing long-term funding to kind of keep the progress and momentum going and continue to improve it, that have been really critical. And you'll hear from me after the panel about some kind of recommendations for next steps, and they'll sort of build off of these key takeaways we're sharing. So with that, I'm gonna hand it over to Alyssa to get the panel going.
Thank you so much, Jillian. That was an amazing wealth of information. That was great. And it is my absolute pleasure to kick off our panel discussion. As part of our research, we conducted a series of case studies to highlight 4 communities and how they were implementing CalAIM. We dove deep on Alameda County, Fresno and Madera counties, which are a 2-county continuum of care, Los Angeles County with a focus on South LA, and Santa Barbara County. It's a terrific look at the bright spots and innovative practices emerging from CalAIM implementation, and we encourage you to check out the case studies themselves. Today, we are joined by 4 folks from those communities who are deeply engaged in CalAIM implementation and can shine a spotlight on how CalAIM is impacting people experiencing homelessness and the homeless system of care. So now it is my privilege to introduce them. Okay, first, from Alameda County, we have Jovan Iglesias. Jovan, LMFT, is the Chief Operating Officer for Bay Area Community Services, overseeing housing and behavioral health services at the organization for 11 years. A stout harm reductionist, he has played a critical role in launching dozens of Housing First programs across the Bay Area of Northern California. Jovan has served as an advocate, activist, supervisor, partner, mentor, and consultant to social justice causes, community-based organizations, graduate programs, and local governments for over 20 years. Welcome, Jovan.
Hi, everybody. So happy to be here.
Next, from Fresno, Madera, we have Miguel Perez Lopez. Miguel currently serves as a program manager of regional housing strategy for Anthem Blue Cross, covering the counties of Fresno and Madera. His current focus is to address housing and services gaps for vulnerable community members. He previously served as the executive director for the Kings Tulare Homeless Alliance, the lead agency for the local continuum of care. He also worked for the Public Housing Authority and has over 10 years of experience in the affordable housing sector. Welcome, Miguel.
Hey, good morning, everyone.
Next up, we have Victor Uribe. Victor is a health program supervisor at Martin Luther King Community Healthcare, where he oversees the hospital's ECM program and teams of community health workers, lead case managers, and RN case managers. He has over 10 years of experience in case management and is dedicated to improving healthcare outcomes in underserved high-risk communities. Prior to joining MLK 5 years ago, he worked at an outpatient surgical center. Welcome, Victor.
Good morning, all. Thank you so much.
And last but certainly not least, from Santa Barbara, we have Sarah Brazel. Sarah is a dedicated housing program specialist senior, serving as the healthcare justice liaison for the County of Santa Barbara's Housing and Community Development Division. With a background in healthcare, housing, and 5 years in local government, she brings a deep commitment to equity, collaboration, and systems-level solutions in her efforts to integrate healthcare and housing resources, strengthening connections to the coordinated entry systems for individuals experiencing homelessness and those who are justice involved. So welcome, Sarah. We're so delighted to have you.
Thank you so much. Wonderful to be here. Thank you.
So welcome, everyone. We're going to dig in. And while I have individual questions for each of you, I also encourage you to chime in on each other's answers. We want to hear from you. The audience wants to hear from you. So first, I'm going to kick it off with a couple of questions about CalAIM and HIP and how they've really changed the nature of relationships between the healthcare and homelessness systems of care. We heard a lot about that from Jillian in her kind of summary, and now we're going to hear it in practice. So Miguel, I'll start with you. HIP really marked a fundamental shift by requiring managed care plans to collaborate with homeless response systems in a very deliberate way. And CalAIM has really required a very unprecedented level of partnership. How did Anthem initially approach building those new partnerships with COCs and homeless system providers? And what changes have yielded the greatest impact for connecting Medi-Cal members to housing resources?
Yeah, I think, from the onset, it was important for managed care plans to really take the time to listen and understand the complexities, the needs, and kind of the status quo for each homeless response system within each community, right? I think the challenge, when you're looking at the implementation of CalAIM throughout California is that each homeless response system looks different in each community. And each community has different barriers, complexities, that you have to really take the time to understand, right? And so I think it was really important to take the time to understand how that COC was structured within that community. In Fresno, Madera, there's no nonprofit that serves as the lead entity. So it functions a little bit different than other communities. It covers 2 counties. Fresno and Madera counties, although there's some similarities in the two, there's also some challenges, right? Because you have some really rural parts within Madera County, some real rural parts within Fresno County, and then you have other parts within Fresno County that are highly populated and really follow more of the challenges of an urban setting, right? And so really kind of, again, taking the time to understand, how is that COC structure? How is coordinated entry system structure and implemented, right? I think that's really understanding when you're looking at how homeless response systems function, with the goal of ensuring that these new housing services are going to be paid through Medi-Cal will be integrated into that system, right? And so, again, learning the challenges, learning the gaps, and at the same time, learning the strengths, right? And so all of that's really took place from just taking the time to listen, learn, and let that information really come from the local stakeholders, right? So really engaging all the key players, right? Your COCs, your local housing service providers, the counties, cities, the cities, and other stakeholders that are part of that, right? So a lot of faith-based communities that do a lot of great work within the housing sector, right? So really engaging all these different stakeholders and really working through that process of understanding what the needs are, right? And that really kind of led to an ongoing conversation that really kind of allowed us to recognize how can we leverage CalAIM services, right? These new set of services and HIP to really address some of those systematic gaps and really build out the infrastructure within that homeless response system to ensure that these new housing services can be properly integrated within that homeless response system, right? And so I think it really, when I think of when CalAIM was being rolled out and HIP was being rolled out, it was really, in my opinion, a lot of the successful investments and a lot of the success that we have had were driven by the needs and the feedback that we received from the community, right? So it wasn't the managed care plan coming into the community saying like, hey, this is what we're going to do. We have this funding. These are our priorities. This is kind of our our vision and our goals, but really kind of let that being driven organically from the community. And I think that really has spoken to a lot of the success that we have been able to see, right? In terms of how, the greatest impact for connecting Medi-Cal members to housing resources, I really do think, and one of the reasons why I made the transition from, working for a COC and coming and joining Anthem Blue Cross was that I think there was a huge opportunity to really leverage a new funding stream to be able to expand services, right? Specifically, when you look at areas like Fresno, Madera counties, and some of these other, other communities within California that were very limited to housing resources and funding, maybe your COC dollars that came from the Department of Housing and Urban Development, maybe some of the state funding that you were receiving. But there, some of these communities have less resources than, let's say, Los Angeles County, San Francisco, some of these larger areas that have other local influxes through other local taxes that are, kind of funding some of their homeless response system services. And so really allowing to tapping into this new source of funding to really expand services that were needed and that were just completely underfunded or they didn't have a significant source of funding. And also looking at it from, I think when you look at, historical, the way that homeless response systems had functioned, they were relying on grants, right? And so sustainability has always been an issue for homeless response system and for ensuring that those services are there. And so really looking at a way of saying, hey, through Medi-Cal, we can really build out, and we have, we spent the time and the time and the money to build out the capacity of these organizations and these response systems to really have a sustainable source of funding to continue to expand services, right? So one of the examples that I like to use specific to Fresno County is that within Fresno County, housing navigation was limited to housing navigation services that were provided in access sites, right? So throughout Fresno County, you had different access sites, usually, available at a emergency shelter or some sort of other interim housing setting. But there was very little in terms of actual, street outreach, right? And so we were able to come in there, We saw that as a gap, as a need within the community, and we made a significant investment of HIP dollars with now one of our contracted community supports housing navigator providers to build out a housing navigation team that was, their goal was to go out there, engage community members out who were in the streets and really kind of build out that infrastructure, right? So I think to me, that's a key example of success and really kind of what the expansion of services has meant for some of these communities, right? I also like to use another example of in Kingston, Tulare County, prior to CalAIM, and this is going to sound like incredible, we only had 2 housing navigators that were funded by COC dollars that provided housing navigation services for 2 counties, right? And so, there's been an expansion of housing navigation services from the onset of implementation of CalAIM. And, we have a lot of the local service providers were already kind of doing that work that have expanded that service, right? And so to me, that's been a systematic just change and a fundamental change to ensuring that, we're going to get more of our community members housed. Understanding it's going to take time and working through that process. So again, I think the greatest impact really speaks into expansion of services, specifically for a lot of communities who were very limited to the resources that were available to them.
Thanks so much, Miguel. And Homebase is pretty deeply embedded in Fresno, Madera. So we've been along for the ride and been able to see this firsthand, and it's been amazing. And I'm sure this concept of this infusion of funding and how to leverage it will come up again and again in this conversation. Sarah, I'll turn to you. Santa Barbara took a really innovative approach by leveraging those HIP dollars to create a healthcare liaison position between the managed care plan, CenCal Health, and the COC, which is you and your role. What has been most surprising to you about how this role has impacted the partnership between homeless services and healthcare? If you have any stories about how this has directly impacted individuals experiencing homelessness, we'd love to hear it, and more about your role.
Wonderful. Thank you, Lisa. Well, yes, I serve as healthcare liaison for our partnership with our managed care plan, CenCal, and the Continuum of Care. Here in Santa Barbara County, we serve as the COC lead. We also run our coordinated entry meetings and systems. We manage our HMIS system. So we wear a lot of hats, but this new role that CenCal allowed us to create, a healthcare liaison, allowed me to focus and be a voice at many tables. As the healthcare liaison, I focused on the supportive efforts to meet HIP metrics, also worked on Medi-Cal renewals in our community, and really focusing on the expansion of provider and community knowledge about CalAIM and CalAIM efforts, including enhanced care management and community supports. I think that knowledge, that community knowledge of what are you talking about? What are these things? So I was able to be out there and, kind of that boots on the ground, a seat at the table, talking about this. I was really that squeaky wheel. Through this role, I was empowered to ask questions and to look for innovative answers. And just listen. I think that's a big thing too, listening to questions, listening to ideas of other departments, of other providers, and bringing those answers and questions together to help form solutions. I now also serve as our department's justice liaison. And in this new expanded role, I have more opportunity to spread that message that we believe, and I think most of you here on the call, that housing is healthcare. We really know that it's that whole person model that works to create change. And now I'd love to share some change that we were privileged to see here in our community. And the success story comes from the Good Samaritan Shelter. Here in our community, they are one of our largest ECM and CS service providers. And I'm going to share with you Sam's journey. His journey is proof of the resilience and transformation that these services can help to support and bring. After spending many years experiencing homelessness, Sam found himself at the Good Samaritan Lompoc, that's a city here in our community, Lompoc Emergency Shelter. Sam began working with the shelter's housing transition navigation team, and with community supports he was housed, marking a pivotal turning point in his life. Now, for years, Sam had avoided seeking medical care due to a distrust of medical professionals, and despite suffering from severe and chronic health conditions, he just didn't want to go. But since securing stable housing and developing those relationships with his team, Sam has made remarkable strides in prioritizing his health. With the help of his ECM case manager, he's established a primary care physician, completed all annual exams, and even visited the dentist, where he became approved for dentures. And we all like to eat. Teeth are a big part of it too. Beyond improving his physical well-being, Sam is now finding meaning by building friendships within his housing community. He's embracing a sense of stability and belonging that he had long been missing. Sam's overall health has vastly improved, and he's thriving in his new environment. He looks forward to a bright and promising future. Thank you.
Thank you so much, Sarah, and thank you for grounding this conversation in, what this is all about. I think it can be very easy to talk about, this policy and that process and authorizations and, all the things that kind of go into complex policy change. And it's just so helpful to be really grounded in the reality of why we're all doing this work, why you all are doing this work. And so I really appreciate that. And I would also say we have the privilege of working very closely with Sarah in Santa Barbara, and we really see that sort of kind of air traffic control role that Sarah plays in her community, and how critical that's been in sort of moving the whole system forward. So really great to hear about your role and that kind of innovative approach. So now we'll shift to talking to how this work is impacting providers and what you all see in your communities. Jovan, I'll start with you. BACS is a leading provider of homeless and behavioral health services. Coming from such a deep experience with the homeless services sector, what knowledge and expertise has your organization brought to delivering ECM and community support services? And how do you think this benefits the members that you serve?
Thanks, Alyssa, and thanks for having me. First, I want to just start off by thanking Sarah for bringing the human element back to this conversation. I think that is at the core why we're all here. So I appreciate you offering that. So Bay Area Community Services, just to give some context for how we've gone about implementing our CalAIM program, is a 73-year-old organization that has a long history of both a housing provider and a behavioral health services provider. We do some smattering of health services as well. And over the course of our history, we've developed, a pretty strong expertise in what it takes to get people housed and keep people housed. In that time, foundationally, our supported independent living programs are really foundationally the essence of who we are and how we've managed to build our organization, now operating in 6 different counties in the East Bay and out through Sacramento region. I'll start off by saying that we are a provider of ECM, the trio of community supports, and we are also a recuperative care medical respite provider. And in all senses, we've really looked to integrate those services to fill in the gaps where all of the other services that we operate don't seem to quite line up or overlap. And we've really seen that need. To give context to that, BACS was an early adopter and participant in the Whole Person Care Initiative, which preceded the CalAIM initiative. And as a operator and pilot provider in the Whole Person Care pilot, we really saw very early on the tremendous variance of need of folks that would then likely enter into those services or be eligible for services through CalAIM. on one end of that spectrum, noting that there was going to be individuals who had fallen through the cracks and really needed light touch services in order to get back on their feet or supported into housing and maintaining that housing. On the other end of the spectrum, we have folks who are experiencing severe and persistent mental illness, long-term substance use and challenges that sort of circulate around that, a whole host of comorbid other factors that really prevent them from staying housed, and a whole host of other issues. We saw this play out in our experience as a full-service partnership provider with our county's behavioral health plan, as a provider of reentry services and AB 109 services. And we've seen this play out throughout our time as a transitional housing provider, as well as a provider of several access points in the coordinated entry system of care and the COC throughout all the communities that we operate. So I'm sharing that to say that we have this pretty broad perspective of who we were serving and who was likely going to be served by CalAIM as CalAIM came on. Noting that, we really created an intentional process to then fill in those gaps, understanding that who we were serving were folks that likely moved through all the stages of change, and that understanding in recovery models that that each person is likely going to vacillate, circulate, and return to certain stages of that change throughout the course of their journey. Knowing that we are a provider of behavioral health services, as well as intensive community supports and outreach services, going into encampments, providing transitional housing, doing in-home supports through our supported independent living, we really created this model where our ECM supports and our community support, community supports through TSS and housing navigation, we're really going to help people navigate each of those. And if they required more intensive levels of services, that they were the bridge to those intensive services. And then as folks recovered and stabilized, they were also the long-term aftercare to keep people into those systems that would then keep them stabilized, vis-a-vis stable, permanent, and or PSH housing, right? The way that we've integrated that more fruitfully and recently is by applying to several home key rounds. Using those home key rounds, we've really stood up a number of SIL programs through converted motels, where we're bringing in dozens and dozens of folks into new units and housing them, and then with a very high functioning, high level county operating with our managed care plan, and that county acting as a service or a contracting hub, we're able to create a system whereby which we're recognizing and assessing folks through coordinated entry, bringing them into those SIL programs, and then providing the CalAIM supports through community supports, through the trio of community supports and ECM, so that they can be sustained in those living units permanently if they choose, or to continue to stabilize and advance into other forms of housing through their journey. So all in all, it's been a very integrated and intentional process. Certainly Bax is unique in that we are a provider that operates a full range and scope of services in multiple systems of care that allow us to see the whole person and then be able to target and say, hey, where are the gaps, right? And let's see if CalAIM and these needed benefits can help us navigate the inflection points in people's lives so that they stay sustained through it, regardless of what their vacillating needs are.
That was so helpful, Jovan. And I think I want to just lift up two things. One is, Jovan, you mentioned the role of the county, and two of our case studies featured counties that are playing this sort of administrative hub role. Just encourage folks to check out the case studies themselves to get a better sense of how that functions, what they're doing, because it's an interesting and innovative model that's popping up certainly here in California. The hub model is also a core part of how other states are implementing these waivers. So it'll just give you kind of a deeper sense of how that's happening. But what I loved hearing is just the really strategic lens you all brought based on your very deep knowledge of kind of different, the population, different segments within this population, really understanding what people were going to need, when and how different kind of services and funding streams could really support those folks. So that's really, really great to hear about. We're going to switch to Victor, who brings a different perspective of a hospital that is certainly experienced in serving people experiencing homelessness, but didn't before have the same kind of breadth of resources to bring to that support. So Victor, as a hospital serving South LA, which has the second highest population of homeless individuals in LA County, how did becoming an ECM and community supports provider change the way that MLK Community Hospital serves unhoused patients? And what kind of outcomes are you seeing as a part of this shift?
Good morning, by the way, and thank you, Lisa, for having me. So becoming an ECM provider here at MLK Hospital has definitely been one of the best things that's happened to this community. I think that, having such large unhoused population, finally listening to the community and knowing what barriers they're experiencing has brought our organization to be able to provide services such as doing bedside roundings. Once our patients are admitted, or even if they're just waiting in our ED, we get alerted. So our ECM staff gets alerted, we go over, we meet with the patient, and we just try and provide any service needed, such as post-discharge appointments, being able to offer just daily essentials, being able to assist them with food resources, clothing resources, just anything that the patient may need right there and then. That's where my team and I come into play. I think one of the biggest, most satisfaction that we have is seeing that, for example, we have many patients that would come to our ED on a daily basis. Now they come once a month. Mm-hmm. So that's a huge win. Another example, having a partnership with our housing navigation team and with our street medicine team has definitely been extremely beneficial for ECM. We have members that, the street medicine team finds, at their tents, and they need, resources, or they need an LCM to assist them with referral navigation, scheduling appointments, medication refills. So, just having that collaboration itself definitely helps a lot, tremendously. And it's a great satisfaction that we feel and see, within our community, and being able to offer all this to our community.
Thanks so much, Victor. That's great. And I'll just reflect, one of the things that we heard across all of our interviews was, ECM in particular, but I think community supports as well, really led to people getting just increasing access to care. Yes. Providers talked about, I'm helping people access primary care and specialty care in a way that they never have before. So that was, really amazing. And I think hearing from your perspective, Victor, this concept of like, if we connect people to the services and supports that they need, it will have an impact on their health. We know this. And so yes. Just hearing you share that from your kind of perspective, I think is really great. Yeah. Awesome. Great. So next, Joanne, I'm going to come back to you for a second. You spoke to this a bit already, and Miguel talked a lot about kind of the potential for these new funding streams to really play a key role in sort of programmatic sustainability and the potential to braid CalAIM with other funding streams and what that might mean. So you talked a little bit about that from like the moving somebody through programs. How has your organization braided funding, and what impact has that had on programmatic sustainability?
Well, thank you for that question. So again, I want to also lift up the just profound support that we've gotten from our county hub as both an administrative hub and a contracting hub, and also as a thought partner in how to craft and deliver these services. I think that aspect of it cannot be, overappreciated. In that, we have been able to braid these community supports, particularly the trio that you speak of, into our contracting with the county for other services, such as our access points, where we can braid funding together as both being a provider that does housing problem solving, matching, subsidy administration, and at the same time within the same team have housing navigators and have care coordinators who are providing the services that are funded through CalAIM. And so we have a separate standing community supports contract and a separate ECM contract. However, those what we call care coordinators in terms of our staffing are embedded throughout the various programs that the individuals who benefit from these services would apply for. So that integration looks like having housing navigators embedded with our interim housing programs for folks who are exiting those programs. We have care coordinators who are providing care coordinators and nurses who are providing ECM services to those folks who are entering our interim housing programs and exiting our interim housing programs. We have housing navigation staff embedded with our outreach teams who are contracted through our COC contracted programs for various different programs. Like we have multiple housing navigation centers embedded throughout Alameda County that have attached outreach services. And so we're able to then embed these care coordinators who can provide either ECM or other services to go into the community, whether they're encampments, where we're doing those outreach services and pair them up with ECM services or anything else. So there's an abundance of ways that we can line those services up and fill in the gaps where someone who is able to provide that care management support maybe be able to have inroads relationally, where someone who is just saying, hey, do you want to come in and get services at one of our coordinated entry sites, or where, hey, do you want to come into one of our interim housing programs, they might not be interested in hearing that, but they might be interested in getting support for a medical need or an infection or something that they haven't been able to attend to because they're not connected with a primary care provider or whatnot. And that begets a relationship. And that relationship begets a different choice down the road. And so when you shared earlier that I'm a stout harm reductionist, this is what harm reduction looks like. It isn't about just handing out needles at a needle exchange or quote unquote reducing the harm. It's about service to the relationship that you have with people so that there is a tomorrow. And because if there is a tomorrow, that means that person has the opportunity to make a different choice. And if they have an opportunity to make a different choice, they can engage and enter those services, those opportunities that are available to them, and then be able to make other choices as well. And so when you ask about how do we braid that funding, it's really through the integration of all of these services. Now, what I think I should also point out is we're entering a time where there's some concern about funding for our housing services, whether we see funding, federal funding through HUD or HUD pass-through dollars through our COC or through our local municipalities, whether there's concern of what Medi-Cal is going to look like and how that's going to be supported down the road. And all of this is it's in the fabric, right? It's in the air right now. And what we're starting to see with some of our partnerships with the system, with our COCs and our local municipalities, is looking for ways to actually build contracting for our interim housing and for our SILs and PSH subsidy units, where we're actually contracting in the housing navigation services and contracting in the TSS and housing trio services into these different services to augment where we might anticipate the loss of funding should that happen. So we're very fortunate to be a part of some COCs that have some great thought partnership and are willing to go down these roads with us and explore what they might look like and pilot them. And again, I just really cannot overstate the value of that.
That's great. And really, appreciate hearing kind of how you all are handling this very uncertain moment. And I think that's, probably helpful for others to hear about. And, what I really like about what you shared across our interviews, what we heard is how CalAIM can either allow communities and providers to serve more people, or people they were never serving before, or allow them to kind of serve the same people, but with new services. And sometimes it's to kind of deepen that service engagement. Maybe they were offering the same service, but now it's richer, now it's deeper, now it's more connected to, integrated. So I think what you were sharing is just a terrific example of kind of how that's manifesting in your organization. So thank you so much for that. Miguel, the audience heard your bio at the beginning, but just as a reminder, you were the executive director for your local continuum of care. You worked in the public housing authority. You were in the affordable housing sector. Now you're at a managed care plan. And you spoke to this a little bit, but why do you think it's important? And we're seeing this trend across certain managed care plans. Why do you think it's important for managed care to bring in people with a housing background? What do you think that does, and what unique role do you play in this equation?
Yeah, so I had a really unique experience. I was still with the Kings Florida Homeless Alliance when CalAIM was barely being rolled out, and we were in the process of being contracted to become a community support provider. And from the onset, Anthem had made an investment and had personnel that came from housing, and I quickly recognized that, um, you know, they were leading the conversation. They were advocating not just for this local housing service providers, but really advocating for the community members, right? For our in-house neighbors, and really having that understanding of the complexities, the barriers that really, are a part of addressing homelessness. And so I think that really, really kind of spoke to me and really made me realize that in order to ensure that there's opportunity to really, um, you know, take advantage of this new resource that was really going to allow us to drastically address the systematic service component gaps within addressing homelessness. It was going to require people that understood housing, that came from housing. And so, I made the transition to join Anthem, and I think for us, it's certainly been a priority and a strategy that has paid off. Right, we have a statewide housing director. I have two other colleagues that also serve as regional housing managers, right? That, really understanding that, the complexities and barriers are unique to each county, and we want to have the internal capacity to be able to really understand those and work through those issues at a local level, right? And so I think that's been extremely, extremely important to really understand the needs, the barriers, and it's really kind of a twofold role that I really kind of see myself driving, right? And working through the internal challenges, right? I think really working to understand that leadership understands homelessness, understands how services are being delivered, what the barriers are, um, and really focusing on ensuring that I'm communicating to them that we need to be patient, right? Addressing homelessness is a very complex problem issue, and it's going to take time, effort, and resources, right? And so I think that's been part of the challenge to be able to work internally as a managed care plan to really understand how these services work and how we can't be short-sighted, right? I think when you're looking at addressing health outcomes, when you're looking at health outcomes from addressing the housing needs and really kind of embracing this whole notion of whole person care, we have to be reminded that it's going to take time, right? It's going to take time. And so I think the investments that we have made through HIP and the investments that we have made with some local housing service providers that did not have the initial capacity to really transition to a medical reimbursement model. And we have been working with them because we recognize that they were the right provider, and they're the right provider that we want to have in our network, and the type of provider that will effectively deliver housing services. It's taken them some time to sometimes onboard them, right? And even through that process, there's a lot of barriers that that they have to work through the implementation stage. And so I think just a constant reminder to continue to advocate for the local CBOs, for the smaller CBOs, but most importantly, not losing sight that we have to continue to advocate for our community members, right? For our in-house members, and to ensure that we understand that it's a very taxing problem, that it's going to take a lot of collaboration, a lot of time, and a lot of patience, right? Especially when you look at CalAIM services and what we're able to do, right? We're limited, right? This is really kind of another arsenal in the toolbox to be able to address homelessness, right? Really heavy and focusing on the service component aspect of it, right? But it's not going to address homelessness or really allow to house people, right? We're not, although we have made some investments in permanent supportive housing and other housing opportunities, where we can't pay for housing. We don't have hundreds and thousands of units we can move our members into, right? So again, really addressing and working internally on what the challenges are, and reminding leadership that this is a long-term investment, and that we will see outcomes. I think addressing housing will certainly produce positive health outcomes, but it's going to take time, right? And so there's challenges within, right? So I think that's part of my role, and just as importantly, I think it's working through on the external aspect of my role, working with our housing service providers, our county partners, our partners in city governments, and other stakeholders within homeless response systems, right? And I think really, first of all, working to ensure that a lot of the local CBOs that had never, engaged or been a part of a medical reimbursement model, and having them understand the opportunity of what, kind of taking this chance and engaging in this and CalAIM, what the benefits were, right? In terms of being able to expand services, and then also build out programs that were more sustainable, right? Really build out these sustainable models, and not having to rely on these cyclical grants that may be here one year and may not be here the other year, right? And so again, really looking at expansion of services and looking at this as an opportunity, right? And be able to communicate with them that, like I had the experience of being on the other side. Like I've been in your shoes. I know what the challenges are, not only within the implementation stage, right, and kind of the development stage of these services, but even now, as we're working through the actual implementation of services, there's challenges that are coming up right now, right? Like budgeting and forecasting is not always going to be accurate, and working with those service providers in terms of, hey, some of this was expected, okay, like let's work through this process. What can we do, right? And so again, really kind of a twofold approach of speaking that language and being a translator both internally and externally, with always keeping in mind that we're doing this to serve our most vulnerable community members, right? And I think the other thing that
sorry.
Yeah.
I just was going to comment on, your role as translator. That's what was coming up for me while listening. And I think anytime you're doing this kind of cross-sector work, it's like, wow, we really speak different languages, different policies, different systems, different perspectives. So I think that the fact that you're there and able to be, crossing these sectors is just really, really powerful. So yeah, that's great. Thank you. Thanks so much for sharing that. I want to shift to little chat about data, which we know comes up again and again, around data sharing, the ability to understand clients, shared across systems, the opportunities and challenges associated with, delivering coordinated care. Sarah, Santa Barbara has a really unique approach to data sharing. Your managed care plans shares information about shared clients back with the COC, including which members have been referred to ECMCS, which providers they've been referred to, whether that provider has connected with the client. Can you tell us a bit about how you built this two-way relationship?
Yes, most certainly. So as part of our collaboration with SanCal, as you mentioned, we do share that monthly. We share a monthly match list. It is currently in Excel, So very, very manually driven information, but it does allow us to see, as you said, the participant status, if they are enrolled with CenCal for their Medi-Cal services, if they have been assigned or enrolled with an ECM provider and who that provider is, and then which community supports have they been enrolled with and what provider is giving those services currently. With an ROI in place, we are able to then use this information during our very robust weekly coordinated entry case conferencing and outreach meetings. And this information helps to highlight Medi-Cal enrollment efforts. So if we see somebody on the list is not yet, in our terms, Medi-Cal verified, we then can push our providers or encourage our providers to help make that connection. If we see that somebody's been assigned to a provider but not yet enrolled, we can ask existing providers to have the conversation with the participant about these services. We know in some cases, participants were being contacted by unknown providers, somebody that they're not currently working with, that call in the afternoon, but who is this? If we can front load that conversation and really help participants understand how these services can and so greatly impact their housing searches and healthcare, they feel more comfortable in having those conversations and moving towards enrollment. The information can also be helpful to highlight if they're currently receiving services within our HMIS system from a provider and they're assigned or enrolled with someone else, maybe there's a reassignment that might need to happen to help deliver services more efficiently, or there needs to be some expanded opportunities for warm handoff or collaborative efforts between providers. Our managed care plan has helped us to find out who the best contacts are at the different organizations delivering these services. So that's been very helpful as well. We also provide back to our managed care plan in that matching process who the participant is currently enrolled in programming in HMIS. And we are hoping that this information will be used in the future by our managed care plan to inform the assignment of those services. So we are very excited to recently have moved to a new HMIS system. We are hopeful that this new system will be able to integrate our data exchange in a way that does not require manual processes, and that it can be something that is in more real time. We do believe that real-time information is most useful. We do know that people, participants can gain and lose Medi-Cal enrollment, for various reasons. Knowing if a participant is enrolled or not enrolled in real time really helps to move those services along. But, I was previously entering all this information manually into a free text field in our HMIS system. I am very excited to not have to do that anymore. But we are continuing to provide for our managed care plan a weekly housing status change report. This housing status change report is really not only been, I think, impactful for our managed care plan, but also for our own system. It's really helping us to see in that weekly snapshot, who's coming into the system, who's getting housed, who's unfortunately losing housing, who can we quickly get them connected to if that's happened, get them reconnected, but also helping to let us see, who has been connected to those tenancy and sustaining services. And that's the big thing that we really see system-wide, is that supportive services post-housing placement for so many of our participants is really the key to housing stability and success. Thank you.
Thanks so much, Sarah. Manual data entry, that is a real labor of love. And I think, hearing all this information, I think it goes back to our prior discussion about sort of your ability to play that air traffic control and like the information that's coming in. So that's really helpful. We wanted to make sure to highlight this because we know so many communities understand the potential and the power of data sharing in this way, and we know it can be challenging. So wanted to kind of shine a spotlight on what you're doing. Victor, last question for you before we open it up to the group. One of the findings in the report was that, a lot of hospitals still don't know about ECMCS necessarily. So curious to hear what advice you would give to other hospitals who are still learning about CalAIM programs or considering becoming an ECM or community supports provider.
Of course, I would definitely encourage them 100% to move forward in becoming an ECM or community support provider. The satisfaction of being able to help our community, especially our unhoused community, is tremendously. Being able to see the success in our unhoused community's health and just being able to navigate their health from not only their actual diagnoses, but also with social barriers, is definitely a very satisfactory.
Amazing. Thanks so much, Victor. Okay, so now I'm going to turn it over to my colleague, Julie, who can just help us do some Q&A quickly.
Thanks, Alyssa. We've had some really good questions. Many we've answered in the Q&A, so if you haven't gotten a chance to look there, please do. But there were a couple that we thought would be good for the panel to answer directly. And the first one is the DHCS dashboard, which is the Medi-Cal dashboard that shows how people are experiencing ECM and CS across the state, has shown that managed care plans are funding a lot of housing navigation transition services, far more than their housing tenancy and supportive services, and housing deposits, which are the services, the housing related services that happen once someone has housing, and supportive services and deposits. And we're wondering what the impact of that has had on reductions in Medi-Cal costs among people served. So we wanted to open that up to the panel. If folks have thoughts. Alyssa, maybe you have thoughts. It is sort of a bigger picture. You all have your roles in the system. It's a bigger picture. I can take a tiny little stab at it, or Alyssa, if you want to take a stab at it.
No, you go ahead, Julie.
I think that you're absolutely right. We've done a lot of analysis. You can see in our data fact sheets that are on our website that housing navigation, I think in general, one of the big issues with housing tenancy and supportive services and why it might be underutilized is the difference about how healthcare perceives an ongoing need for someone who's in permanent housing for supportive services as compared to how the homeless system of care does. So the homeless system of care, as you all know, for permanent supportive housing, the supportive services are needed in order for the person to stay stably housed for as long as they're needed. And healthcare looks at it through a medical lens and like how long are supportive services needed for medical purposes. And sometimes that interpretation is 6 months or 12 months. So it's very limited. And the way that the system going back and forth with two different payers in a system may make it for the homeless system, let's just put them in the permanent supportive housing and have it be paid through the permanent supportive housing providers. So I think that conflict in terms of the interpretation of what supportive services are needed and how they're medicalized version versus a holistic healthcare version is, I think, part of the dynamic. So I think that would be one. But Jovan, please join in.
I think it's a fascinating question, and perhaps there can be more research on how to coalesce that data. I know that for BACS, we've had to bring in multiple data sources to really get a true picture of that. Again, because we're talking about community supports, and it's hard to medicalize that information. But if you look at it from the standpoint of individuals and where they would likely show up and receive medical care, you see the same essentially population showing up more frequently at emergency room departments and urgent care departments for those more routine and benign or issues, physical health issues or medical issues that would otherwise be more readily serviced through a PCP or through an FQHC or through other more routine and preventative care models for healthcare. How it relates to housing is that for folks who go through coordinated entry and are matched with housing and or go through a coordinated entry or an access point and get matched to interim care, and then are fortunate enough to then get into permanent subsidized housing or some housing match, if their services, if they're not offered aftercare services or ongoing services, the key point is that 6-month period after being housed, and they are more likely than not to recidivate back into being unsheltered or back into homelessness in that critical period if they are not receiving ongoing care and supports. And this is where ECM and this is where community supports and that trio can be extremely valuable to fill in that gap and that connective tissue that otherwise provides that space for them to continue to build skills and abilities to sustain their living, to continue to then get connected to primary care through an FQHC or some other more preventative and routine model. And then they are less likely to then return back to their environments because that's the support, or that's what they're used to, or that's what they know, or that's what they maybe perhaps fall back into because they are learning to or needing to self-medicate, or they're looking for resources in other ways that otherwise don't fit their current need to stay sustained in their housing. And so to answer the question, how does this reduce like emergency care or reduce like a Medi-Cal utilization and other things like that in terms of billing and pay? Well, it shows up in this way. They're not showing up to emergency rooms as much. They're not showing up to urgent care as much. And for a healthcare plan and for a community of taxpayers, that shows up in the bottom line. And then, someone once told me, if you're in this for the dollars and cents, then you have no sense. But the reality is that our unhoused population they cost our community much more than what we see. It's all of our burden. And if we can keep them housed, then we're actually reducing the likelihood that they're going to use these urgent healthcare services.
Alyssa, do we want to take another question, or do we want to move to a wrap up?
I don't know. Maybe if there's one more brief one, and then we can
Yeah, this one might be brief. And just asking folks, if you have an answer, if we can just keep it brief. But the question was, can people talk about people who have successfully been able to use housing deposits and how long that process took to get approval? I can answer one part of that question. Was the payment sent to the landlord? Yes, the payment goes directly to the landlord. So anyone would want to answer the question about what the generic time frame is for housing assistance through the housing deposit?
Yeah, so for our members, it's 5 days. If it's urgent, we can expedite it up to 3 days. And then anything that's being submitted through our ability system for our contracted providers works a lot faster. And then for non-contracted providers, they can utilize our Find Help to submit that authorization or referral.
Right. Thanks, Miguel. Anyone else want to talk about how long it takes in their community really quick? Okay, Alyssa, I think that is probably good. And we put in the chat, if we didn't get to your question and we thought we were going to answer it live, we put our email in there to ask us, and we will follow up with you. So thank you.
Thanks so much, Julie. And thank you so much to our amazing panelists. I think if we were in person, you would all be receiving thunderous applause right now. So really, really appreciate it. Appreciate the work you do every day and your time with us today. So with that, I'm going to send it back to Jillian, who will just kind of wrap us up.
Thanks, Alyssa. So much. We have, I'm really grateful to all the panelists, like Alyssa said, for how much you were able to share. And thank you so much to everyone, as Julie mentioned, for putting so many great questions in the chat. I know we didn't get to all of them, but we answered a lot in the Q&A if you want to take a look. And like Julie said, you can email us if you have more. I'm just going to go really, really briefly. And again, we'll send out these slides, all of these recommendations and wrap up. Alyssa, if you want to go to the next slide, are contained in the reports themselves, but just wanting to let folks know that we have recommendations. You know, you heard from us at the beginning, but then also more importantly from all the great panelists about what actual ECM and CS, especially like implementation, actually looks like. And so we wanted to just make sure folks are aware that we also have included in our reports and wanted to share some highlights of just like continuing to look forward to continued improvement in ECM and community supports implementation, and also some recommendations that are intended for if there are future similar types of programs that are meant to kind of facilitate collaboration between health and housing systems, either in California or in other states as well. So there are some recommendations we have for just like program development to kind of keep in mind for sort of maybe similar new programs. So I'm going to move into some of the next slides because I want to focus a little bit more on just like continued recommendations for ECM and community supports. These are some additional program development, just like considerations. And again, I hope folks will take a moment to go back to the slides when we send them out or look more deeply in the actual materials themselves. But again, it's just kind of some considerations to think of for future similar programs. Alyssa, you can go to the next slide. And I'm going quickly through these, y'all, but we wanted to emphasize you all hearing directly from the implementers. So just a couple of recommendations thinking about that we wanted to lift up in terms of implementations for like actual support for communities and for local implementation and planning that state agencies and counties like should certainly consider or like should certainly do for new programs, but even for programs like ECM and CS, which are already ongoing, like to kind of continue to provide just like, you know, we mentioned there's still a lot of folks who are eligible and not yet connected. So just making, you know, wanting to encourage like more and more inclusive and broad outreach and messaging and education about the fact that these programs exist, they're still available, what the services are, how folks can kind of get folks connected to them. You know, continuing to share guidance and implementation and technical assistance. We have here as a recommendation, like as early as possible, which is certainly true, but also kind of continuing throughout implementation. So even for these existing programs like ECM and CS, you know, continuing to provide guidance. And then really numbers 3 and 4 are a little bit more about, you know, kind of like making sure you're set up for success early on. But again, things that continue to be important in terms of continuing to encourage standardization and transparency and just like making sure folks are aware of all the different requirements and policies and processes. And then we also, we have, if you go back one, Alyssa, just a couple of recommendations, and these are really more focused on like continuing to strengthen local implementation. So these are all extremely relevant for continued ECM and community supports implementation, even though we're, you know, a few years in and many of you are doing this already. But just wanting to highlight, and there's, you know, details kind of explaining each that you can see on the slide, but also again, read more of each of these is explained in more detail in the report in the ECM and CS specifically document, but wanting to lift up a couple key strategies, just like continuing to, as much as possible, make the processes involved in getting folks like both referred to and connected to ECM and community supports more simple, more streamlined, more accessible, continuing to provide even more support for providers in terms of both like trainings and TA and funding, helping to support the administrative requirements, building opportunities for like providers to speak to each other, to kind of engage in some peer learning and mentorship, continuing to try to make these more financially sustainable for providers, including looking at braiding of funding, since CalAIM can't cover everything for a lot of folks, being able to negotiate rates that actually cover, you know, more the realities of how it is to provide these resources, things like that. Again, continuing to, we've seen a lot of great movement in terms of integrating systems in certain communities. And so wanting to just like continue to encourage folks to really standardize things, really kind of connect the COCs, processes, and systems with to actually kind of integrate ECM and CS into those processes as much as possible. And then, of course, we talked a bit about data sharing during the panel, but just wanting to make sure folks are aware that the state is continuing to put out guidance and actually like materials to help support better data sharing and information, data sharing systems and information sharing. And just wanting to really emphasize that that's such a critical piece of this care coordination, and the referral piece itself is being able to share information across systems. So really looking at doing more of that and diving into that more at the local level to kind of continue to improve implementation. We just have, one thing we want to note, and actually the coming shortly is now, you can download your fact sheet by COC, by your county, and also look at all of them together. And we're going to have some office hours where we'll dive into kind of how to use these data fact sheets, but just wanted to make sure folks are aware of this. This is a part of the suite, and that you can kind of look at, you can actually look at the sort of comparison of who is most likely to be, or the numbers of folks in your county that are likely to be eligible for these resources compared to who is actually accessing them, to get a better sense of like where there is room for really making sure you're doing some outreach and education and connecting folks. And all the data that's on there is linked to the sources, so you can see even more updated information from the state. But just really wanted to like lift up that these are available. And then again, we really encourage, if you're interested in thinking about how to apply, how to use these fact sheets, and also just like how to engage with and use all of this wealth of information that we've shared during this webinar and that are in our report materials. We really encourage you to register for. You can use that QR code or the link, we'll put it in the chat, to come to one or both of the office hours, because we'll really get to dig in with folks in even more detail, answer additional questions you have, but also really like talk through like how to actually use all the information in these reports in your local community. I think we're probably out of time for final questions. So again, wanting to link one more time how you can sign up to keep in touch with us. Again, another plug for the office hours. Check out the report materials. Even though we had an hour and a half, we just kind of touched the surface of all the great information that we've been able to collect from communities and providers across the state to build these materials. So really, really appreciate you all attending this webinar coming. Thanks again so much to our panelists. It was really wonderful to hear directly from folks who are on the ground doing this work in communities. Appreciate everyone's engagement and attention, and hopefully we will talk to or see you soon in the office hours or in our emails or another webinar sometime soon. Thanks so much, y'all.